It's a pleasure and honor to be here today, and really to be among some of the top fertility specialists in the world, my distinguished friends and colleagues. What I wanted to let all of you know is that during the panel's discussions, if you have any particular questions, go ahead and text Shelley at that particular number. You can text her up until 9:40 a.m. And at the end of the discussion, what we'll do is we'll take a sort of collate some of these questions and ask the panel in regards to your specific questions. So with that said, as you know, we've talked a little bit about your surrogacy journey and how really it could be divided into three parts. You know, you have the initial assessment of sperm and your sperm freeze and FDA screening. Then there's the egg donor selection. And then subsequently, once you have created embryos, and for many of you, you're going to freeze your embryos and then wait for your surrogate, then there's the surrogate selection and screening. And of course, you have the embryo transfer and the initial pregnancy monitoring. So our distinguished panel is going to address every one of those steps so that you get a very good idea as to the entire steps in your medical journey. Your doctors are not only responsible for the success of your journey, but they're also responsible for the health of your egg donors, the health of your gestational carriers, of your surrogates. So they really play a very critical and important role in your journey. And of course, they're going to accompany you. They're going to hold your hand throughout your journey. And I think that they're really a very great first step in regards to your consultations to map out your journey to parenthood. With that in mind, what I would like to do is introduce our first doctor, my friend and colleague, Dr. Amanda Hurliman from ORM Fertility, and she's going to talk to you about egg donor selection and screening. How do we select an egg donor? Who are the egg donors that are ideal to donate eggs in terms of egg quality? And she'll talk to you a little bit more about that particular process. Dr. Hurliman?
Good morning, everyone. It's a pleasure to have the opportunity to speak with you today. My name is Amanda Hurliman, and I'm one of the physicians at ORM Fertility in Portland, Oregon. And I'm going to find my slides. There we go. So I'm going to spend some time today, the time that I have with you, focusing on the screening process that egg donors go through and some of the factors you might want to consider when choosing the right donor for you. Specifically, we are going to talk about the characteristics of an optimal donor and why these characteristics matter. We'll go over the screening tests that donors complete to ensure they're going to be a good donor. And lastly, we'll focus on some of the factors important to your decision-making process, like should we use a known donor or an anonymous donor? Should the donor be proven, or is it okay to use a first-time donor? And what about fresh versus frozen eggs? So what characteristics help us to define who is an optimal donor? She will ideally be young, between the ages of 20 to 28. However, some programs do accept donors into their early 30s. She should be physically and mentally healthy. The donor's medical history will be reviewed, and most programs will have upper and lower limits for BMI. The donors will receive psychologic clearance before being invited into a program. She should not use tobacco products or illicit drugs. This is becoming somewhat of an issue as cannabis is being legalized in more and more states, and I think just individual programs are defining the protocols that are working for them. In most programs, egg donors are going to complete a urine drug screen prior to their cycle. Family history is extremely important, and it's reviewed during the initial screening process. Some donors won't pass the screening process just based on their family history alone. But the thing with family history is that everybody has one and everybody comes with one. So the most important thing is that you review the family history and receive the education that you need to understand what it means for your children. We want donors to have good ovarian reserve. Ovarian reserve is an evaluation of the quality and the quantity of the eggs that are within a woman's ovaries. And we want to ensure that she has a healthy supply, sufficient supply of eggs. And last but not least, donors should exhibit the appropriate motivation and desire to be the best donor that they can be. And in my experience, most do. Egg donors undergo an extensive screening process prior to the cycle. Sometimes this screening is completed before a donor is invited to be in a program, and sometimes the screening is not completed until after the donor has been selected. It's just going to depend on the program that you're working with. The donor will need to obtain medical, genetic, psychologic, and legal clearance. She will have a complete physical exam performed by her health care provider or at the clinic. She will complete infectious disease screening and also undergo ovarian reserve testing, again, to look at the quality and the quantity of her eggs. Genetic screening of donors is extremely important. A thorough family history will be obtained, and the donor will have blood work done to look at her carrier status for recessive genetic diseases. So these are diseases that in order for a child to be affected, both the egg provider and the sperm provider would need to be carriers of the same disease. If this were to be discovered during the screening process, the child would be at risk for developing a genetic disease like cystic fibrosis. So the most simple thing to do in that scenario would be to select a different donor who is not a carrier for that particular disease. Donors will undergo psychologic evaluation by a licensed professional, and they will complete standardized psychologic exams. So why does age matter? It matters because age is the best predictor for having a healthy child. So the deal is that as women, we're born with all of our eggs. We have one supply, and we work with that supply over the course of our lifetime. So from the minute we make our eggs, we start losing them. So as the eggs get older, there's a decrease in quantity of eggs. But as they get older, there's also a change in the quality of the eggs. And that's due largely to an increase in chromosomal errors within the egg. The chromosomes contain the DNA and are basically the instruction manual for making a baby. And so if the chromosomes are not in the right order or there's not a right number, it's difficult for healthy development to occur. So this table is illustrating the percent of embryos that are chromosomally normal as the eggs get older. So in a woman under 30, in the egg donor column there, generally 60 to 65% of the embryos that are created from the egg donor cycle are going to be chromosomally normal. Whereas if you have a woman in her early 40s, only 20 to 30% of those embryos are going to be chromosomally healthy. So now we're going to go over some of the factors that you may be considering or should consider in your decision-making process. The important thing to note with the next few slides that I'm going to go through is that there is not a right answer here. As you work through this process, you're going to find what is right for you. Oops. So is it better to use a known or an anonymous donor? An anonymous donor is someone that you would connect with through an agency. A known donor is someone that you would bring with you. Using a known donor is going to provide you a more personal experience. There can be some pros to this, and there can also be some cons, as you can imagine. You'll be more likely to have long-term access to the donor if it is someone that you know personally. So this provides you with the ability to learn about the donor's future medical and family history as it develops. Oftentimes, with a known donor, the donor is going to want to meet the children if this is something that you would like to do. Most people, though, use anonymous donors. However, the degree of anonymity is driven by what you and the donor agree to. Anonymous donors are easier to find, and you will have a larger pool to choose from. Since you do not know them directly, the process can often be less complicated, and it may be potentially legally safer. However, you're going to have legal contracts in place regardless of which option you choose. So, should you use a proven donor, or is it okay to use a first-time donor? So a proven donor is somebody who has cycled before, and so they come with a track record, which is information that's available to you. So you can see how many eggs were retrieved, you can see how those eggs fertilized, how the embryos grew, and if genetic testing was performed, what percentage of the embryos were chromosomally normal, and have those embryos resulted in a pregnancy or live birth. It may be a less expensive option because many of the screening tests that need to be completed may not need to be repeated. And the donor is going to be more experienced, so there's less likelihood that she may have an error. With first-time donors, there's more of them, and so you're going to have a wider selection. They're oftentimes younger because they haven't had the opportunity to go through multiple cycles. So there's a possibility that you can have a first-time donor where when we've done her ovarian reserve testing, it looks like she has a really high number of eggs, but we don't have the assurance about the quality of those eggs until we try. So is it better to use fresh or frozen eggs? So egg donor cycles can be done in a fresh cycle. The donor will cycle, and all the eggs that are retrieved from that cycle will be the eggs that are provided to you. In a frozen cycle, you will get a certain number of eggs that had previously been frozen, and you usually get a set number. So with a fresh cycle, you're going to get as many eggs as the donor can provide, so you can get a high number of eggs, and oftentimes a higher number of embryos, which can then be frozen and used in the future for sibling cycles, so you wouldn't need to go through the process again. The success rates when we look at using fresh eggs versus eggs that have been frozen are higher for fresh cycles. Frozen cycles are going to be less expensive because you're getting a smaller group of eggs from the donor's cycle. It's very convenient, the eggs are there, they're available to you, and oftentimes you'll be able to access more eggs in the future if you want to go through another journey after the donor, quote unquote, ages out. And is no longer, doesn't fit into the age category where we would accept a donor. So there's a lot to consider as you go through this process, and like I said, the most important thing is to just have the conversations that you need, educate yourselves the best that you can, and you're going to find what's right for you. Thank you.
Thanks so much, Dr. Hurliman, about your insight into egg donor selection and screening. I'd like to introduce Dr. Mousa Shamonki, a good friend and colleague, and he's going to talk to you about the selection and screening of gestational carriers. Who can be a gestational carrier? Who can be a surrogate? And what are some of the testing that we do and perform in order to ensure the health of your surrogate as she goes through the pregnancy, and also to minimize any complications during pregnancy? Dr. Shamonki?
Good morning, everyone. Of course, I echo my fellow panelists at what a pleasure it is and a true privilege to have the opportunity to speak to all of you today. So, let's talk about how to find a great surrogate. We're going to talk about what characteristics define the optimal gestational carrier or surrogate and why. We're also going to talk about the medical review and testing of a surrogate in order to make sure she's an appropriate applicant and determine if she can safely carry your baby. And also other important factors like agency-oriented versus independent, and first time versus repeat, and we'll go over those in fine detail. So let's talk about selection of and screening of the gestational carriers, and specifically what characteristics define the optimal gestational carrier and why. So we want to make sure that the surrogate has a true, sincere desire to carry your baby. Because as you can imagine, there's a great deal of money being given to the surrogate, and you want to make sure that they're doing this for altruistic reasons. So you also want to make sure that they are medically fit and healthy to carry your baby. The first and most important thing we ask is, do you have an uncomplicated pregnancy history yourself? Because if they have a significant problem with their prior pregnancies, that could be a significant red flag for you in terms of her ability to carry your baby. You want to make sure she's ideally less than 40 years old, ideally does not smoke, is in excellent health, have a body mass index of less than 30. You do not want her to be in the obese category because there is a greater risk to not just your baby, but to her as well, of high blood pressure and diabetes in the pregnancy. And you want to make sure that she lives a stable lifestyle. You want to make sure that the environment around her at home is healthy and safe. And you, very importantly, want to make sure she has no history of mental illness. And the process to identify that surrogate will go through detailed, for example, psychological evaluations, et cetera, to make sure that they are not just physically healthy, but psychologically healthy as well. So what medical review and testing do surrogate applicants undergo in their screening to determine that they can safely carry? So once we take a full history, and very detailed history about their past, not just medical problems, but their social history, et cetera. They'll also undergo a complete physical examination. And we also very carefully review their records, because we don't just take what they tell us for face value. We want to look through the records. I've very, very many times had surrogates tell me everything was fine, and then you look through the records and identify something that's significant that might impact the next pregnancy. They then undergo a vaginal ultrasound to ensure that the uterus appears healthy, that there are no abnormalities within the body of the uterus that might negatively impact your chance of carrying the pregnancy. And they also undergo infectious disease testing, which is mandated, actually. So everyone has to undergo the same mandated routine STD screening. And then they go through a very careful psychological assessment to try to weed out any patient that may be doing this for potentially nefarious reasons or for the non-altruistic reasons. And then the surrogates undergo a full medical instruction, not just about the surrogate process, but about the procedures themselves and also the risks. It's very important that we treat the surrogates like anyone else, like someone who's about to undergo some very important medical procedures, but these are human beings that are very special as well, and we want to make sure that they're safe and healthy. So, how do you pick between a first-time surrogate and a proven surrogate? Because as you can imagine, there are potential differences between the two. With a proven surrogate, they have a known track record. They've carried that baby and delivered that baby almost always with a great outcome. Otherwise, they wouldn't be coming back to be a surrogate again. They're more experienced in that they've gone through the process. They kind of know the back and forth about coming into the office, meeting with the physicians and making sure that they go through that process, take their medicines appropriately, and have done so successfully. They're usually older and perhaps less likely to do sibling journeys. Now, what about first-time donors? There's going to be a wider selection. they're usually younger, and of course, they're less experienced and usually also less expensive. But remember, when you're looking at proven versus first time, they have a proven obstetric history. So they've all carried a pregnancy, they've all delivered a baby or babies. And so in a way, they are both proven to a certain extent, just a little bit different in that one has gone through the surrogacy process. And if you have a great center that can guide you through the process, that difference between proven and first time may be minimized. Should geography affect your choice of surrogate? I would just say face value, the answer is yes, because certain states have far more favorable laws than others. But your surrogate will need to be available to various people in various places with regards for interviews, testing, taking medications, monitoring embryo transfer, pregnancy monitoring, and delivery. And so your surrogate will need to be available to various people in various places, and therefore, does she need to be near an agency? And again, this is very, very complex. You want to make sure that your surrogate is in a safe environment, has access to care, is available, and is willing to travel potentially to those places if they don't have those resources in close proximity to them. So I'd like to thank you all for your attention, and I'm going to pass the baton off to Dr. Ghadir via Dr. Daneshmand. Thank you very much.
Thanks so much, Dr. Shamonki. As Dr. Shamonki mentioned, many of these criteria that we use for gestational carriers are really important, including things like the body mass index. So it's really important for you to discuss these issues with your doctor. Sometimes clinics can have variations in their criteria, including body mass index. As you know, body mass index can potentially predict the risk of gestational diabetes and high blood pressure. So make sure you have a good, thorough discussion with your doctor about all of these criteria. Dr. Ghadir from SCRC, good friend and colleague, is going to talk to you about the medical process, meaning how is the egg retrieval performed and what are some of the requirements in terms of FDA testing of intended parents and egg providers. Dr. Ghadir?
Good morning, everybody, and welcome. It was a pleasure meeting many of you guys yesterday, and thank you guys for coming by and telling us about your story, and we're excited for all of you to start your journey. Congratulations. By getting up early on this Sunday morning, you have now passed the first step of never sleeping in again, so welcome to that. We're going to be talking a little bit about the medical process, my favorite part, of helping this entire journey and what the surrogate and also the egg donor are going to be going through during this process of preparation to make you your beautiful babies. So the medical process. What is the pre-testing does and what does a doctor have to do is a really important part of this. We actually have a specific amount of tests that we do that my colleagues talked about, and the FDA requires certain testing that we do, and we do a really good job. And a lot of what we do is to protect you and to make sure that everyone, surrogate, donor, intended parents, everyone has the healthiest outcome. We're also going to be talking about how the actual egg retrieval is performed, because it's very surprising to people how we get eggs out of women. So we're going to be talking and explaining that, and what are the risks of the procedure, and also the risks of the medications that are going to be used during this process. And I'm also going to be touching base on the usual range of numbers of eggs, which there's no usual, but give you guys some guidelines on what to expect in this process, so there are no surprises for anyone going down the path. Okay, so the medical process. The medical process of pre-testing, the FDA has a certain list of tests that an egg donor has to do, the surrogate has to do. In our office, we even require that the surrogate's husband or partner, if she has one, has to do as well, just to make sure that everyone is in good health and everyone is following guidelines. These FDA testing involve a significant amount of blood work. Again, tests that even I wasn't aware of until I went into this field, but things to protect everyone. And also an extensive questionnaire. The questionnaires are about like 12 pages long, asking 1 million questions, things that protect you. For example, if there's been any recent tattoos, if there's been travel to Zika zones, all things that could potentially affect a future healthy egg and also the person carrying the egg. And in our office, and I'm sure in every single office, the physical examination and evaluation of the egg donor and also the surrogate are very, very important. Usually, a very, very important phone call is the second I'm done with the screening of both an egg donor and especially the egg donor, because most of the time these are anonymous. I immediately like to get on the call with the intended parents, letting them know exactly what I thought about the egg donor and how I think she's going to do. Most of the time, these are lovely people that are really dedicating themselves to doing this. They don't make a ton of money from doing this, so there definitely has to be something in their heart that wants to be helping everyone, and I believe many people have that, and I just want to make sure I feel that. I want to make sure that I tell the intended parents that I really think she's going to do a great job and give you guys great eggs. And also, of course, physically, she has to meet a lot of criteria that we want in order to make sure that she's going to do a very good job and in a healthy manner for you guys. The physical exams actually are done in 2 different steps. Usually they come with a baseline set that is done, and then they do them again. They don't have to be done 6 months apart, but they have to be done in a certain amount of days before the actual eggs come out. The FDA testing that's also going to be done on all intended parents has to be done within 7 days of the collection of sperm. For our office, since we have a lot of people flying in from around the world and around the country, all of it is done in 1 day. So the day that the sperm is collected and frozen is the same day that the questionnaires are done, the blood work is done, the physical exam is done. And that's why it's very easy to be able to do this with a clinic that's not necessarily in your hometown, because generally 1 visit and you're all done with every single thing that needs to be performed. So the medical process. How is the egg retrieval performed, and what are the risks of the procedure, as well as the risks of the medications which the donor takes leading up to the retrieval? So once the egg donor has passed all the testing, you guys have searched every single egg donor in this country and picked the one that's going to be absolutely perfect for you, which I'm sure every single one of you will find. The intended fathers will give us a sample of sperm that is usually frozen and tucked away and brought out the day that the eggs come out so we can thaw it and use it. Hopefully and ideally before that time, sperm has also been evaluated. You've been given some feedback on any issues you may have, anything that you could have done to improve it, to make sure that you're using the best sperm sample that's available. And during that time, the egg donor, the egg and the sperm at that time will then be fertilized together with the in vitro fertilization process. For just some knowledge, the word in vitro means outside of the body fertilization. So the egg and the sperm are fertilized in the laboratory environment, and that is exactly what IVF is. We let these embryos grow for about 5 to 7 days in the lab environment, trying to make the healthiest embryos that you're going to be potentially using in the future. And once these embryos are available, that's when we then start the process of a frozen embryo transfer, which is how we do them in our clinic. The frozen embryo transfer allows us to have complete control on when you find your surrogate. It can also be the same thing that is done for baby number 2 or baby number 3 from the original batch of embryos that's tucked away and saved in our office for you to use for siblings. So what your donor will be asked to do, like I said, the complete full array of screening and the FDA testing, the complete instruction and counseling regarding every step of the process. One of the things that we take a lot of pride in doing in our clinic is that we have an entire division called our third-party division, which is a very large group of nurses that are absolutely and only dedicated to helping anyone using an egg donor and a surrogate. And they go through this entire process with our surrogates, of course, and also our donors. And we meet with them as physicians ourselves to go over the process as well. I think when picking and selecting a physician, making sure someone that communicates well with you, and also that means that they're going to be communicating really well with your egg donor and surrogate, are incredibly important. And I think my goal for everyone who comes in and out of my office is to make sure they completely understand everything I've told them before moving on to the next step. The process, it says here, that takes 6 weeks of multiple medications, mostly injections, to develop follicles, usually around 20. I want to clarify this a little bit. The process always begins for the egg donor by notifying us when her menstrual flow has started. We usually have her go into a local place or close to us if she's local in our area. But they go in for blood work and ultrasound, usually on day 2, 3, or 4 of the cycle. If everything looks good, the way that we proceed is putting them on a birth control to kind of just stop the cycle get the ovaries kind of synchronized, get everyone at what we call a baseline level without them ovulating that month on their own. And as a result of that, once their body is at complete rest, all the clearances and everything is perfectly done and all the testing has come back normal, then we proceed into the process of daily self-administered injections. It could be administered by a friend, yourself. We allow people to learn how to do it. We go out of our way to make sure they completely understand. Our clinic sends videos to people so if they get confused, they can call. We have 24-hour-a-day nurses on call and physicians on call to answer questions. Yes, we do get calls at like 1 in the morning that I got confused on something. How do you do it? Happy to clarify. I'd rather do that than have no errors going forward. The injections usually go into the belly. The injections usually last for about 10 to 12 days. These are the injections that trigger the brain, and the brain then triggers the ovary, and then the ovary starts to create estrogen, which is the fuel for making these eggs. The eggs grow in a follicle. So on the ovary, every month when someone ovulates in the middle of the month, there's a follicle that releases. By doing this process that we're stimulating the brain, we're getting multiple follicles to grow. So instead of the ovary just having one, we get these ovaries that get rather large. And hence the one side effect that almost every single egg donor is immediately feeling is this feeling being bloated. Well, you have these ovaries that are normally this big, and a couple weeks, like about within 10 days, you have these ovaries that are like this big. And ideally, for your situation, the more number of eggs that we get, the healthier outcome. So these ovaries kind of grow. The growing of these follicles, every single follicle is kind of a casing for an egg. And we're going to go, as a physician, I'm going to show you guys that process, into these follicles and remove these eggs that we're going to use later. This is about a 10 to 12-day process of injections, usually involves about 4 to 5 visits to a monitoring clinic or to the clinic where they're the closest to. And we do a lot of this remotely because a lot of our donors are around the country. And eventually, within the last week of the process, they come into the clinic where the eggs are actually going to be retrieved. And the process kind of just ends there with the egg retrieval. The undergoing of 4 to 6 weeks of follicular monitoring, again, it's about 10 to 12 days of follicular monitoring. It's not 4 to 6 weeks. There's a baseline ultrasound, one in the middle, and then it's that 4 to 5 visits. So they're not going in for 6 weeks straight of testing. And during those last 10 to 12 days, it is just about 4 to 5 visits. So this is really important stuff because being safe and ethical in the treatment of your egg donor is incredibly important to everyone, and beginning with her being fully informed and consented, of course, is extremely important. And everyone goes through a consenting process where we go through step by step by step everything that's happening. We also make calendars for every single egg donor and every single surrogate. So they look at the calendar on a daily basis, letting them know what they need to do next, what's involved on that day, and how to proceed. The fertility medications stimulate the ovaries to develop multiple follicles, ideally between 20 to 25. That is not set in any way. You must have a clear discussion with your doctor because when a donor goes in for initial testing, there's some important tests that are done. There's an incredibly important blood test called AMH, anti-Müllerian hormone. That is the hormone that comes from every little egg in the body. So when you check that in a donor's blood, if her AMH level is very low, she probably has a very low reserve of eggs and may not be an ideal donor, especially for a couple that needs to divide those eggs into 2 and use 2 sperm sources. So getting an AMH level that is adequate and your physician telling you that you think it's going to be a good number in order to make a good number of eggs is probably going to be the most crucial part in picking a good donor and making sure that someone has a great reserve of eggs. The side effects, like I was saying, is that incredibly uncomfortable feeling of being bloated. It's a very good signal. If an egg donor is not feeling bloated, my number one concern is that she's probably not making a lot of eggs. So that feeling of bloatedness, as long as you do a really good job letting people know in advance, you will be feeling bloated. And after your egg retrieval, you're going to be feeling even more bloated for that week after while you're recovering. Setting expectations, I think, for every single person involved in this journey is really, really important, and especially for the egg donor because they do get rather uncomfortable. There is a complication from getting too bloated. It's called ovarian hyperstimulation. When the ovaries start to get really large and when the eggs are retrieved, afterwards these ovaries start to leak fluid, and that fluid kind of fills inside of the belly and makes an incredibly uncomfortable feeling. One of the things that has come back up in the last couple of years is a medication called Dostanex that we give to donors, which really reduces the chances of hyperstimulation. And I'm sure that all of my colleagues as well, we are incredibly careful not to overdose a donor and to monitor them regularly and go down on the medications if we see too many eggs are growing. Just to make sure that they have a very safe outcome, we want to give you guys the best outcome by getting the most number of eggs, but the health of the egg donor and this whole process is also incredibly important for everyone. There's no proven association between these medications and any type of cancer. I like to make that very clear because all of our patients have these misconceptions in their heads. The egg retrieval involves, in our office and in most offices, a very light sedation. When the egg donor presents, our center has our own surgery center, which is right next to the clinic on the same exact floor. We have an anesthesiology team. They put a little IV. In the IV, they inject a little bit of medications, and your egg donor is going to have the best nap of her life for about 5 to 10 minutes. And then the eggs are retrieved vaginally. There's an ultrasound that's placed vaginally. On the side of the ultrasound, there's a little port for a special needle, a hollow needle that goes right through the vaginal wall and into every single one of those little follicles. So all those little casings that grew during those 10 to 12 days is now a house for a little egg. The needle goes in, and then with a little foot pedal, we suction, and it goes into a little test tube that gets passed right to the Ivf Lab in our office. And right behind that wall is our embryologist that's telling us during that time how many eggs we're getting. So by the end of the procedure, you should be getting the amount of eggs that you had the number of follicles for. And at the, right then and there, and again, one of the best phone calls for me is immediately calling the intended parents and telling them how many eggs we had. At that point, our Ivf Lab then introduces the sperm and the egg together, and the entire process of watching embryos growing begins the next day with a phone call that I make to intended parents saying we had this many eggs, we divided them in half, and then as a result of that, we now have this many fertilized, and the fertilized embryos are the ones that we're going to be watching grow for the next 5 to 7 days. An important thing is there's also no proven association between egg retrievals and subsequent fertility or infertility. We are not sucking all the eggs out of a donor. She can have kids of her own again whenever she wants. Every month when someone is releasing that one egg, during that process about 1,000 eggs kind of die off. We're trying to recruit some of those eggs which were going to die off anyways, so we are not putting her into an earlier menopause. We are not removing excessive amounts of eggs to make her chances of having her own kids go away, or doing anything at all that's going to affect her fertility overall. So the usual range and number of egg retrieved in a typical donor, how many should be expected to fertilize and grow? These are really, really just estimates, guys, and every single person does a little different. It has a lot to do also with sperm quality, so I don't want to put all the blame if something doesn't go perfect on an egg donor. That's why we want to make sure that everyone has an optimized situation before proceeding. But an expected yield from a typical egg donor in a healthy woman is something between 18 to 24. We've had ranges of up to like 35. We've had some people, barely make 18, and these are things that you need to be aware of. But in an example that someone gets about 20 eggs, let's say about our success rates for fertilization are over 80%. Here we're giving an example of 14 to 18. As a result of those, 12 to 14 of them grow to day 3. In our office, we let all embryos grow to day 5, 6, or 7, which is the full-grown stage of what's called the blastocyst. Every single one of you was a beautiful blastocyst at one time or another. And as a result, those blastocysts are available for genetic testing. We highly encourage our patients, and after going through everything you're going, most of you guys, I'm sure, are going to want to do genetic testing. The genetic testing not only gives you the gender, which is a nice thing to know, but it also checks for the health of the embryo, making sure that it's completely healthy, and situations like Down syndrome or any other chromosomal abnormality are kind of checked for, and you make sure that the embryo that goes back is healthy. As a result, you get these genetically normal embryos, which are all of your future kids, that are then cryopreserved and tucked away in our offices. And those embryos are there for you to use the next month for your embryo transfer, and you can decide which embryo, which genders, from which person is then transferred into the surrogate. Thank you, everybody.
That was great. Egg donors play such an important role, critical role in your journey. They're just amazing people. And the new techniques that have been developed have really decreased the risk of complications such as ovarian hyperstimulation syndrome. I remember in the old days, and I'm old enough to remember the old days, the risk of hyperstimulation was something significant. But now with new techniques and new stimulation protocols, we've really eliminated that risk for egg donors. Well, my good friend and colleague, Dr. Guy Ringler from California Fertility Partners, is going to talk to you about the development of the embryos and how do we select the best quality embryo to transfer. When the uterus of the gestational carrier of your surrogate is ready, how do we assess among a group of embryos the best quality embryos and the healthiest embryos to transfer to the surrogate so that we maximize the chance of a healthy pregnancy for you? Dr. Ringler?
Thank you, Saeed. Well, I feel like a lucky guy this morning. Not only do I get to stand up here and talk to all of you, but I think I got the best topic today. I've always been fascinated by cell culture ever since as an undergraduate student at the University of Michigan. There's something fascinating about watching cells in culture and watch them grow and develop and to see what they do. And in our field, these little cells in a culture become beautiful little babies someday. So we are all clinicians. We evaluate the egg donor, we evaluate the sperm donor, the gestational carrier. We monitor the egg donor during the process. We retrieve the eggs, and then we hand this material, these cells, to our embryology team to do the next step. So I feel honored to be able to explain a little bit of what they do inside the Ivf Lab. And for years, the Ivf Lab has been somewhat mysterious. You know, patients never knew what happened behind that door. 3 years ago, we built a new Ivf Lab, so I told our architects, I need a window in that lab. I want to walk my patients down the hall and let them see what's going on in there where their embryos are created, and it's great. The embryologists love it. We wave to them in there, and patients can see where your embryos, where your babies start their lives. Pointer. Okay, inside the Ivf Lab. In my brief presentation, I have 3 objectives. I'm going to talk about what happens in the Ivf Lab from the day that we get the eggs until day 6 and 7, when the embryos are frozen, how we evaluate the embryos, how we grade them, how do we select the best embryo for transfer, and lastly, genetic testing of the embryos, as Dr. Ghadir talked about. We biopsy, do genetic testing to provide more information on the embryos. We still don't have the perfect way to evaluate an embryo, and the ultimate goal of our science is to be able to test these embryos in the Petri dish in a non-invasive way to obtain information that will tell us which embryo can make a baby, which embryo does not have potential, which embryo can make a healthy live-born baby. I'll get this right eventually. So I retrieve the eggs in the operating room, and in our operating room, in our surgery center, we have a window into the Ivf laboratory. The eggs are collected and they're transferred directly into the Ivf laboratory where they're assessed by our embryology team. They're immediately placed in the incubator for a couple of hours before they're prepped for insemination. And there's 2 general types of insemination. Traditional IVF involves mixing the eggs and sperm together. And with healthy eggs, healthy sperm, we expect about 65 to 70% of those eggs to fertilize. However, if there's any sperm issue, low sperm count, low sperm motility, the fertilization rates can be much lower. You can end up with 0 to 50% of those eggs fertilizing. So ICSI was developed in the early 1990s, and it's a form of assisted fertilization. In the ICSI procedure, an embryologist selects one normal appearing, normal moving sperm, and under the microscope, they inject it into an egg. Now this will give us a fertilization rate of about 80%. So absolutely, if there's a sperm problem, we're going to do ICSI. In our program, for all of our egg donor cycles, we do ICSI just to ensure an optimal fertilization rate. So we could best take advantage of all those eggs retrieved from your egg donor. The day after egg retrieval, the day after ICSI, considered day 1 of culture, the embryologist will look for signs of fertilization. So on day 1 of culture, we have a fertilized egg or a 1-cell embryo. Now, if we looked at those embryos every day in culture, which we don't, you could see signs of development on a daily basis. So day 1, it's a 1-cell embryo. Day 2, it has 2 to 4 cells. Day 3, 4 to 8 cells. And then day 4, they sort of morph into this blob where you can no longer count the individual cells, and that's called a morula. And then between day 5 and day 6 of culture, this embryo becomes a sphere of over 100 cells called a blastocyst. So to us, a blastocyst is a usable embryo. We could transfer that blastocyst directly into the surrogate's uterus. A second option is to freeze it and to transfer it into the surrogate's uterus at a later point in time. The third option is to biopsy it for genetic testing. So if we biopsy it, we're going to remove 3 to 5 cells from the outer layer of that embryo and then freeze it and send those cells to the genetics lab to tell us if it's genetically normal. In our laboratory, we now have a continuous culture system. So we look at the embryos on day 1 for signs of fertilization, and then we keep them undisturbed in culture until day 5. Because there is evidence that every time you take that petri dish out of the incubator, the embryo is subject to changes in temperature, pH, which may have an adverse effect on its development. So we're finding higher blastocyst formation rates, higher quality blastocysts by keeping them undisturbed in culture. So we expect somewhere between 50 and 60% of 1-cell embryos to become blastocysts, some on day 5, some on day 6, and a few on day 7 of culture. Once they become a blastocyst, then they'll either be frozen or biopsied and frozen. Now, so this is a picture of some blastocysts. And a blastocyst, again, is this sphere of over 100 cells and is differentiated to an outer layer of cells that are the future placental cells and an inner cluster of cells referred to as the inner cell mass. Is there a pointer here? Great. So these are the outer layer of cells here, and if can you see this sort of cobblestoning appearance? These are the placental cells, the trophectoderm, and this is referred to as the inner cell mass. These are the future fetal cells. So blastocysts are graded according to their degree of expansion, anywhere between 1 and 6, and then they're assigned a letter grade that evaluates the appearance of the cells. A, B, and C. The first letter being the appearance of the cells of the inner cell mass. The second grade is the letter is the appearance of the future placental cells, the trophectoderm. And in general, I tell my patients A is excellent, B being very good, and C being average. D is not so good. D embryos, they're showing some signs of degeneration. And in our laboratory, we don't biopsy a D embryo, but we'll biopsy an A, B, and C. And so we use this information, these grades, to help us in selection of which embryos to transfer. So we're going to transfer the embryos of the highest grade first. And embryos develop within the confines of a structure called the zona pellucida. And this is a glycoprotein membrane that surrounds the egg and the initial embryo. Before the blastocyst implants into the uterine wall, it has to hatch out of the zona pellucida. And so this hourglass shape here is because the blastocyst cells are pushing out of the zona pellucida, so it's hatching. So eventually it's going to hatch entirely in order to implant into the uterine lining. So the appearance of the blastocyst, the grade of the blastocyst provides us some information on its pregnancy potential, but it doesn't tell us everything. As we've learned earlier this morning, even in a young, healthy egg donor, 30 to 40% of those eggs in a given cycle will be chromosomally abnormal. Well, that chromosomally abnormal egg can become a beautiful grade A blastocyst. So genetic testing, PGS, pre-implantation genetic screening, pre-implantation genetic testing, is a way to provide further information on the chromosomal makeup of that blastocyst. We all have 46 chromosomes. Some of these embryos will have extra chromosomes, they'll be missing chromosomes, so that the genetic testing does provide additional information. It tells us the gender of the embryo, if that's important. So in most of our patients utilizing donor egg and surrogacy today will elect to have genetic testing, but it's optional. We know that genetic testing has been shown to significantly improve outcomes in older women, over the age of 37. Our egg donors are 24. Studies have shown there's a trend towards higher pregnancy rates and lower miscarriage rates, but in most studies, it hasn't achieved significance yet. So it is optional, but it is very helpful. What we're finding today is we're getting more and more blastocysts. I've had cases where I have 18 blastocysts, and half of them look beautiful. How do we select the best one for transfer? The genetic testing does provide additional information in your selection criteria of which embryo for transfer. And the way that we do obtain the cells is once it becomes an expanded blastocyst, the embryologist will use a laser and make a little hole, a little breach in the zona pellucida, and they'll extract 3 to 5 cells from the trophectoderm. Again, we're not touching the fetal cells, the inner cell mass. We're just taking the future placental cells, and then they freeze the embryo. And the success rate of this procedure depends a lot on the experience of the embryologist and the Ivf Lab. I think when all of our embryologists started doing this about 10 years ago, it was a little frightening at first, because if I showed you a video, and I didn't show it today, because it's a little scary to see these embryonic cells being stretched and pulled, but studies have shown that it does not have adverse effects on that embryo, on its future development, or in the offspring. So that depends in a large part, I think, on the skill of the embryologist in the laboratory and their experience doing the biopsy, as well as the freezing and the thawing of embryos. 10 years ago, our preference would always be to transfer a fresh embryo into the uterus, and we would freeze the extras. Today in our laboratory, our success rate with thawed frozen embryos is the same as fresh. So we no longer have to do a fresh embryo transfer. So we create embryos, freeze them, and then we'll do a frozen embryo transfer at a later point in time when the surrogate is available. But I think it's important to talk to your IVF program to find out what their experience is with both PGS and freezing and thawing, and ask them if there's a difference in pregnancy rates between fresh and frozen. Our goal is to help you have the highest chance of having a live birth. And everything that we do is to try to make the best conditions possible. I want to give my IVF laboratory the highest quality eggs, and that's impacted by the age of the woman producing the eggs, her prior experience, her medical history, but also how those ovaries are stimulated. If we remove the eggs too early, they'll be immature. If we push the ovaries too hard, we can overcook those eggs. So I want to give my IVF laboratory the perfect eggs, and then I know my embryology team is going to do all they can to make the best embryos possible. Again, to give you the highest chance of having a baby. Thank you all.
Thanks, Dr. Ringler. So as we're following the medical journey in this particular field, what I want to make sure is that you guys all have, if you have specific questions, to text your questions to Shelley at 714-714-714. 814-515-9602. So after our last speaker, we'll have a chance to really address your question specifically. Dr. John Norian from HRC, a good friend and colleague, is going to talk to you about the embryo creation, but also initial embryo transfer and pregnancy monitoring. As you know, we monitor the pregnancy throughout the first trimester, and then we refer your surrogates to their OBGYNs after about 10 weeks of gestation. And Dr. Norian is going to talk to you about embryo transfer and the early pregnancy monitoring.
Again, it's so wonderful to be here, and I commend all of you for being up early on a Sunday. Thank goodness for tea and coffee. So with that, here we go. So what I wanted to do, I get to talk about the fun stuff. I get to talk about the embryo transfer, the early pregnancy, and how we monitor that and ensure healthy outcomes. What I wanted to focus on today are three main topics. I wanted to talk a little bit about the transfer technique. We also wanted to talk about the pros and cons of transferring a frozen embryo versus a fresh embryo. And then lastly, to also speak about, should we transfer 1 or 2 embryos? So here's a little video, I love this video, of someone like myself transferring an embryo into the uterus, into a perfectly primed uterus. You can see myself guiding using an embryo guide, which is basically the size of a piece of angel hair pasta, and transferring the embryo right here delicately into the uterus. And this is a time where the surrogate is in the room, a family member or a friend of hers, potentially the intended dads, the future dads. It's basically like having a pap smear, except we're listening to spa music. It's very relaxing, it's very calm. And myself, this is where the attention to detail of being hyper-specific about where we transfer the embryo comes in. So we do many, many things to ensure that the embryo is transferred in the correct spot, making sure we don't go too far where we might touch the dome of the uterus and cause a uterine contraction that may decrease our pregnancy rates, or transfer it too low where we don't get it into the prime, sticky, receptive spot of the endometrium. Here's a cartoon diagram of that, just sort of showing, again, the soft catheter, the angel hair pasta, guiding that into the uterus and into the prime implantation zone. So what are some things that our surrogates will be asked to do as we get the lining receptive and prepare the lining for embryo transfer? So again, you heard about how we evaluate the surrogates. These women are extremely kind, empathetic women who want to help others with family building. So honestly, they're very conscientious people who are willing to take medications to get their endometrium perfectly primed. So this is where we give natural estrogen, natural progesterone. We're basically giving a woman estradiol. That's what she makes anyways. And we get the lining receptive and favorable. We make sure to monitor the lining, ensure that it's over 7.5 millimeters. I think the prime zone is when it's 9 to 13 millimeters. We want to make sure that it's triple line pattern or trilaminar. These are markers that the endometrium is receptive. During that time, she goes through monitoring visits. We typically use birth control pills when she has her menstrual flow to synchronize the implantation cycle. And then very precisely, we give a tailored number of days of progesterone to make sure that the receptors on the endometrium are sticky. So people, reproductive biologists, dedicate their lives to studying these unique proteins involved in endometrial receptivity. But this is where we, as reproductive specialists, we'll tailor our treatments. The side effects of these medications, estrogen and progesterone, are essentially minimal or none. We're giving people their own hormones that they would produce naturally. In terms of embryo transfer, the greatest risk is the risk of multiple pregnancies, and we'll talk about that when I come to 1 versus 2 embryos. So let's talk a little bit about fresh versus frozen transfer. So previously, we would do a lot of fresh transfers, especially with couples struggling with fertility issues, which many of you don't have fertility issues. It's just that you haven't exposed an egg properly to your sperm, in that you're gay. So that being said, the role for fresh versus frozen, when you look at the national Sart data, Sart is our main professional society where we as reproductive specialists are required to report our pregnancy outcomes to the CDC and more traditionally to Sart. And you can see the national data shows only a small difference in fresh versus frozen. Each clinic at HRC Fertility, we looked at this early on and we continue to look at this. And this is where we've found that our pregnancy rates are equivalent or slightly better when we use frozen transfer. Now, the big caveat with this is it's essential for you to work with a laboratory that regularly freezes and thaws eggs and embryos. So their technique is really tightly honed in. The embryology and Ivf Lab needs to be expert to do this reliably. Regarding single versus double embryo transfer. So I tell folks this is a little more of a discussion that you need to have with each of your providers, hopefully ourselves. So you might notice that pregnancy rates are higher on a national level whether you transfer 2 versus 1 embryos. What we've seen in our clinic is that our pregnancy rate is about 10% higher if we transfer 1 versus 2. The big issue, though, is the risk of twins and the risk of multiples. And that is less of a risk for the gestational carrier per se, but it's more of a risk that I worry about as your physician for the babies. And it's the main risks are the risks that are associated with prematurity. And this stuff is serious in the sense that we're talking about respiratory distress, brain hemorrhage, bowel problems. When babies are born too early, they just don't do as well. Just a quick phrase that we use is babies do better if they grow one at a time. Now, that being said, what is the risk of prematurity? We look at this as a society. So if we have twins, less than 32 weeks, that crazy early scary delivery stage of pregnancy, is anywhere between 5 to 15%. Between 32 and 37 weeks pregnancy, typically babies will deliver about 25 to upwards of 40% in certain studies. And baby twins will deliver full term 40 to 60%. That's always the goal, is for every baby to deliver full term. There are other risks for the mother with twins. These include the risks of diabetes, preeclampsia, C-section, and other more complicated pregnancies for the gestational carrier. The other thing to consider is the risk of insurance. Remember, twins are a higher risk pregnancy, especially a high percentage of twins will deliver and need to be in the NICU or the neonatal ICU unit. And that itself can get expensive, especially for our international couples who have a hard time getting insurance. So that is where the surrogacy agencies can come in to play, and they can really talk you through that. The ideal, just to tell you, and we've done this many times, is to transfer a single embryo into 2 surrogates. And that's the safest outcome, where babies do best, they grow best, they're biologically related, they have the same egg donor, and they're around the same age, but they ultimately will have less disease during their lifetime because they delivered full term. So early pregnancy monitoring, this is where we, myself, will continue to monitor the surrogate. We do this up until the first trimester. So the initial is the 12-day wait. So after embryo transfer, we usually check pregnancy labs approximately 12 days after the transfer to ensure that she's pregnant. We also check an estrogen and progesterone level in addition to the HCG level, which is the pregnancy hormone. We then monitor her early. We do ultrasounds at approximately 6 weeks, 7.5 weeks, 9.5 weeks, make sure that the baby is developing well. And then when the baby reaches about 10 or 11 weeks, we hand the baby off to board-certified obstetricians who will feel very comfortable monitoring the baby and delivering the child, and who we know as reproductive specialists who are very comfortable handling cases that involve a third party, that involve our gay dads. So that's where we as reproductive doctors is, oh, you should see this doctor, she's awesome, or another obstetrician. In terms of delivery room, prenatal visits, to be fair, this enters into the realm of the obstetrician and the surrogacy agency, but many surrogates are so dedicated to the process and want to be peripherally part of your lives, they many times can help with breastfeeding. Everyone's a little bit unique. And in closing, what I would wish to all of you is to be as informed as possible. Each of you all came to this conference, which is wonderful. You guys are going to leave this afternoon armed with so much more information than others. Create and sustain an open dialogue with your medical team, with your surrogate. In terms of egg donors, I think the idea of open donation to some level, whether you set up a Skype, whether you FaceTime, whether you meet her for coffee, there's different levels of an open egg donor. In this day and age, none of us are anonymous in terms of genetic testing, 23andMe, or facial recognition software. So the age of true anonymity is really not there. So the idea of having some level of good communication with all the members is key. Again, be flexible, be open, exhale, breathe. Science matters. The science and the technology we've been talking about works. It's awesome. So with that, I'll leave it to Dr. Daneshmand and the panel, and thank you so much for allowing me to speak.
Thank you so much, Dr. Norian. So we actually have about 20 minutes for some questions, some of your questions that you've texted over to Shelley. In regards to anonymity, there was a great lecture that was given by one of my dear colleagues, Lori Myers at Nashville, about how actually some people are using these recognition softwares to identify their donors within about maybe 20 seconds. So having said that, the first question, I'm going to just go ahead and sort of in order and start with Dr. Ringler. The first question from our intended parents is if they have a known egg donor, a friend, a family member that they like to use that's outside sort of the criteria that we've discussed in regards to egg donor, how would you counsel those intended parents in regards to success rates, number of embryos?
Well, for women undergoing in vitro fertilization, age is probably the single most important factor because as you saw, as a woman's age increases, the percent of eggs that are abnormal gradually increases. So I would want to know the age of that egg donor. For anonymous donors, we recommend ages between 21 and 30, although you can go up to age 35. My very first gay patient I treated, they wanted to use the sister as their egg donor, and she was 41. So I counseled them that at age 41, the success rates are going to be lower, the miscarriage rates are higher. It's important to do ovarian reserve testing on the known donor because that will provide additional information. If the 41-year-old makes a large number of eggs, it just increases the odds of having normal eggs, normal embryos. If she has a low AMH predicting a low response, it's going to be more challenging. But the known donor undergoes the same evaluation as an anonymous donor. We're a little more lenient on our requirements. We'll let her be a little bit older as long as the patients are informed of the risk.
I have another question for Dr. Shamonki, and that is that I'm sure many of you have a question in regards to maximizing the quality of the sperm. So intended parents are asking, is there anything that we can do to maximize the quality of sperm before we come into the clinic to freeze our sperm, to maximize the chance of success?
That's a very complex question. Thank you, Dr. Daneshmand. Well, there's the obvious, which is optimize your health. You want to make sure that you eat a really great diet, that you exercise regularly, that you take a multivitamin if possible. And then ultimately you'll give your sperm for semen analysis, and even if you're in optimal shape, it does not always translate to a perfect sample. It can be far more complex as to whether or not one will have normal sperm despite being perfectly fit and healthy. But you do want to be as fit as you can to maximize your health, which will maximize your sperm's health. Now, when the process starts for a fertility cycle and in preparation for fertilizing eggs, there is evidence to show that daily ejaculation or every other day ejaculation leading up to giving your sample for the eggs will actually optimize the quality of the sperm. So there's something called DNA fragmentation, and there's a particular study I'm thinking about where men with poor DNA fragmentation ejaculated daily over a week, and then they retested their DNA fragmentation. It dropped significantly. And so we would recommend that you do frequently ejaculate, the old term, use it or lose it. So, I would describe by that. But thank you.
Yeah, I'm going to go through the questions that were sent to Shelley. If you want, text your question to Shelley. So I'm just going in order of when the questions came in.
I think you need the number again.
The phone number.
Oh, the phone number again. Oh, okay. So it's 714-515-9602. Great. For Dr. Ghadir, couples had questions in regards to PGS, and once you do the biopsy, are there any ways in which you can assess the embryo afterwards to make sure that the embryo hasn't been affected by the biopsy? Has it regained the cells that it's lost prior to embryo transfer?
Thank you. I think that's an excellent question. I'm a little passionate about genetic testing on embryos. When we had our first child and then had a miscarriage afterwards, we didn't get pregnant for 1.5 years after. So when we eventually ended up doing IVF ourselves, the genetic testing is which led to have beautiful boy and a girl, which I selected a boy and a girl selfishly, but it worked out perfectly. The genetic testing gives you a lot of information. So not only is genetic testing and screening done on intended parents and the egg donor that's going to check for specific disorders that you could be passed on from generation to generation. We want to make sure that two people do not carry the same genetic disorder. The PGS and PGD testing that we do in the office on the embryo and the Ivf Lab, that's checking for the 46 chromosomes. So all the 46 chromosomes are checked, the X and the Y, that's why you get the gender revealed as well. If you don't want to know the gender, we conceal it from people all the time. But that's when we check to see how the embryo is doing. The success of how well you do depends a lot on the lab's ability. Many labs have technology and embryologists that are amazing at doing this. We have in our office, I think, less than a 1% chance of losing an embryo from doing that procedure, but I can't say that's the same for everyone, and I think it's very, very important to understand who's doing the biopsy and also what their successes are and what is actually the rate of damage that happens. This tells you a lot about the genetic testing and the genetic well-being of the embryo. One of the other things that we do is, and a lot of research has shown, because we would be transferring these embryos and sometimes have no success, is that research kind of came out and said that the structural well-being of the embryo is also important as well. And as Dr. Ringler said, they have a way of letting the embryo grow without disrupting it a lot. We are very fortunate because we have these special incubators called embryoscopes. It actually takes about 1,000 pictures of a day of the embryo dividing. The embryo never has to come out of the scope during the 5 days of growth. It continues. It's not exposed to light, to air, to movement. It's not manipulated in any way. But we watch these 1,000 pictures a day at the end of the 5 days like a short little video, and our embryologists are trained to see if they notice any kind of abnormal divisions. We always recommended this as a great tool. It's a few $100,000 incubator that gives you great outcomes. But at the end of 2018, a large research, which was like a meta-analysis comparing a lot of research on the embryoscopes, kind of has shown an increased rate that has now shown significance. So we can tell our patients that the use of something like this that gives you well-being about the structure as well is also proven to give higher pregnancy rates. So looking at the genetic testing and picking the healthiest and making sure it's being done in a lab that knows what they're doing with the biopsy and the genetic testing, and also looking at the structural well-being of the embryo really allows us right now to be able to pick the absolute best embryos and have the highest chance of success with implantation.
There's a quick question about whether the donation of eggs affects the egg donor's ability to, or fertility, or to get pregnant. And I think one of our specialists, your specialist, answered that question, is that we don't have any evidence in the literature that donating eggs has any impact on the future fertility of your egg donors. Another question for Dr. Hurliman is, if we have a friend who has never been pregnant before, would you allow her to be a surrogate?
No.
Now, do you want to say more?
That's the short answer. And I think pregnancy is complicated, and just from a physical perspective, and so ensuring that your surrogate is able to carry healthy babies to term is really important information to have when choosing your surrogate. But I think almost more importantly is that pregnancy is a very emotional time for a woman as well. And a lot can change during a pregnancy for someone. And so it's really important that they have had that experience and understood kind of those changes that are going to happen with their body, with their mind, emotionally and physically, to prepare them for doing that for someone else.
Just want to add one little thing. If you've never had a baby of your own and you don't know what it's like to kind of give it away, it may be a major problem doing it for the first time for someone else and having to hand that baby over to someone else. So I think that's why everyone really, really recommends someone who's had a baby before so they can understand the emotional ties as well.
I think your initial answer, Dr. Hurliman, reminded me of this an encounter I had once with a very old lady. I passed by her and I said, "Excuse me, do you have the time?" And she said yes, and she just moved away. So. For Dr. Norian, there was a question in regards to, based on a woman's cycle, a surrogate cycle, how do we determine the best time for embryo transfer? How do you essentially determine the receptive phase of the uterus, when is the best time to transfer the embryo to maximize a chance of pregnancy?
Thank you. Again, a wonderful question. And so what we do during an implantation cycle typically is, when a woman has her menstrual cycle, we will bring her in, we'll make sure that everything looks good from an ovarian and uterine point of view. We'll place her on birth control pills, and then we can time exactly the day of transfer. This is helpful for the surrogate herself, it's helpful for the future dads, so that we can time things. After we stop the pills and synchronize, quiet the ovaries, we typically give estradiol, give estrogen, and we give that anywhere between 10 to 14 days as a way to build the lining, the building blocks of the endometrium. And then after doing that ultrasound, it's very particular how many days of progesterone we give. Reproductive biologists, I think I mentioned during my talk, have dedicated their lives to studying the number of days of progesterone and published papers on it, manuscripts. Most reproductive specialists will give 5 complete days of progesterone and then do the transfer on the morning of the 6th day. That being said, there is a further test that's sometimes performed called an endometrial receptivity array, or it's a ERA, or it's a test where we can do a mock cycle, and instead of doing the transfer, we'll do a little scratching of the endometrium and then send it to a laboratory where we can do a microchip analysis to make sure that the number of days of progesterone is perfectly tailored to that woman. In the published studies, they suggest that we get it right 80–85% of the time. Now, these published studies are done by the people who've performed the test and developed the test, so me as a cautious reproductive specialist who reads literature, I always get a little cautious when I'm reading reports published by the company that's also presenting the data. Other groups have shown some benefit. I think the ERA is good, more particularly when you have people who've had implantation failures. I restrict it more towards that. To be fair, it's another reason why I think transferring one embryo is not only safer for the baby, for the gestational carrier, but we also oftentimes will have extra embryos. God forbid if there's not an implantation, then myself can get even more compulsive about the endometrium in tailoring that window of receptivity in doing something like potentially an ERA or an endometrial scratching. So I hope that answers the question, but I know it's a little lengthy, but we do ultrasounds, we do blood tests, and then there's other options we can look into to really analyze the endometrium further.
So I have another question, and that is when, and go back to Dr. Ringler, is then when do you decide that PGS is indicated in particular cases, PGS or PGT, pre-implantation genetic testing? I think we have 4 or 5 more minutes potentially, so Dr. Ringler, in regards to PGT?
I recommend it for all older women, ages 36, 37 and older, absolutely. Women with history of repeat pregnancy loss, recurrent miscarriages. And my patients using donor egg, we discuss it. I tell them it's optional. It may provide some benefit, and it should lower miscarriage rates. I think it provides more information, so I think more and more patients, even with donor egg, are electing to do PGS. It does tell you the gender, which many of my gay patients want to know.
Follow up to that question, Dr. Shamonki, if the intended parents don't opt for PGS or chromosome testing, is there anything they can do in the first trimester of pregnancy, so sort of to assess the risk of chromosomal abnormalities such as Down syndrome?
Thank you, Dr. Daneshmand. Just to briefly add on to the discussions about genetic screening of the embryos, it's not a perfect test, and I know it's been expressed, but it does help guide you, but it is not a perfect test. And the reason why we know it's not a perfect test is when you put that single embryo in that is normal, it doesn't stick and become a baby 100% of the time, despite everyone's best efforts. It may stick, depending on the center or the person doing the transfer, anywhere from 60 to 85% of the time. But believe it or not, some of those will still miscarry, even though it's a normal embryo. And then the live birth rate, depending on the study you read or the clinic that you discuss it with, can range anywhere from high 40s to mid 60s. It's not 100%. And that's because the test itself is not perfect, and whether it's the biopsy, although that's probably the least likely in an experienced lab, but the test itself does not give you the complete assessment of the embryo. Think of it as telling you the number of pages in a book, but not the words on a page. It doesn't tell you the fine detail where there may be a subtle abnormality that might be lethal to that embryo, but the genetic screening itself will not detect that. So it's not a perfect test, but it does help guide you. It has certainly reduced the number of embryos transferred, where most clinics, at least reputable clinics, are now putting one embryo in for the vast majority of patients, and that does allow for a safer outcome. Now, with that said, that was a long-winded prelude to what I'm going to say. Let's say you don't do genetic screening of the embryo, and you put the embryo in, and the patient gets pregnant. How do you monitor that? You actually start monitoring from the very beginning. That first beta-HCG, the first pregnancy hormone, there are studies demonstrating that the lower it starts off, the poorer the outcomes, or if it doesn't appropriately double over a couple of days, that can be a sign that the embryo is not developing well. And if the embryo does not progress normally and the fetus does not develop normally, almost certainly that was a genetically abnormal baby or fetus. And nature has a way of kind of filtering out these abnormalities. If, however, it is developing normally, we would appropriately assess roughly weekly for the first few weeks of development to make sure it's reaching the appropriate milestones. And if it does, we then graduate that patient generally to their OB somewhere around 8, 9, 10 weeks, depending on the clinic. At 10 weeks gestation or beyond, you can actually non-invasively, by drawing blood from the person carrying the pregnancy, assess the fetus. And think of it as testing the embryo, but doing it through the woman's blood, because the test, called non-invasive prenatal testing, can differentiate between mom's genetics and the fetus's genetics, and can tell you with accuracy in the mid-90s that the fetus does or does not have the appropriate number of chromosomes. So that's one way of doing it non-invasively. There's also ultrasonographic evaluation in the late first trimester that can also further assess if an embryo appears to be structurally normal or if there may be abnormalities that might suggest genetic abnormalities. You can then take it a step further if there's any concern by doing the invasive testing, which does carry a risk of losing a normal baby, and that's why we don't just jump straight to the invasive testing. Either something called chorionic villus sampling, CVS, where you can test the placenta for that fetus, or amniocentesis, which you could do a little bit later, generally 15 to 18 weeks, which is taking the fluid around the baby and assessing the genetics of the baby. Hope that was helpful.
Thank you so much. We're sorry we couldn't get to every question, but we promise that your specialist will actually send you replies via text in regards to the remainder of the questions. So I wanted to really thank my dear colleagues, these wonderful experts today, for their time and all the information. Have a wonderful Sunday.